everybody, and welcome to my presentation today. My name is Dr. Fiona McCulloch. I'm a naturopathic doctor, and I've been in practice for close to 20 years in Toronto. I'm the medical director of White Lotus Integrative Medicine, which is a women's health clinic. We practice in the area of fertility, endocrinology, and women's health, and we've been doing that for close to 20 years now and serving thousands of patients in our area. I'm also the author of 8 Steps to Reverse Your PCOS, which is a comprehensive book on polycystic ovary syndrome, the topic of my presentation today. First, I wanted to thank Lauren Brown for providing this amazing opportunity for patients and practitioners to connect. My topic today will be about the genetics and what we call epigenetics around PCOS, especially with an emphasis on egg quality. Since this is a fertility related lecture, I'm going to focus on egg quality, but this information will apply to PCOS in general, looking at the overall condition and how it can be transmitted through generations. So what are the symptoms that are common in PCOS that we see? So there are specific symptoms that are very common markers of this condition. One of them is hirsutism, which would be facial hair growth, ovulatory problems, or oligo-ovulation. So what does that mean? That means difficulties with ovulation. Typically what we'll see is with these patients is they don't get periods very often, or when they do get them, they're far apart. So our average period length is cycle length is 28 days from one period to the next. With PCOS, we'll often see that the cycles are 35 days or longer, so those far apart periods. And some patients don't get periods at all unless they take hormonal help. Infertility is a common symptom, so patients may have trouble conceiving and taking them a longer time to conceive. Obviously, without ovulating as often, it takes longer to conceive. Acne is another symptom that you'll see, in particular adult acne on the jawline. And androgenetic hair loss. So the type of hair loss that we'll see in PCOS is it tends to start at a young age, so in the 20s. It progresses gradually throughout the life, and the hair loss is typically at the top of the head, and the central part becomes wider. There's often also dandruff and oily scalp along with that. And then finally, many patients with PCOS have difficulties with their metabolism, so they might gain weight very easily and they have trouble losing weight. And a lot of my patients who have PCOS, I see them working really, really hard and doing things that work for other people, and it's not working for them, and they keep getting told over and over that they should just lose weight. Well, unfortunately, it is not that easy to do so with PCOS. So how do you get diagnosed with PCOS? There's 3 criteria, and you need 2 of the 3. So the first and top one is androgen excess. This can mean clinical or biochemical. So clinical androgen excess means signs of too much testosterone that are affecting the skin or the hair. So generally what we'll see there is the hirsutism, around the jaw, the chin, or acne on the jawline, or the hair loss that I described as well. Oligo or anovulation, meaning that the person doesn't ovulate in 14 days in their cycle. It takes them longer to ovulate, or their cycles are longer than 28 days apart. Polycystic ovaries on ultrasound. This is a very controversial one because a lot of people can have polycystic ovaries on their ultrasound and not have PCOS. And then there are many patients without PCOS that don't have these ultrasound appearances. So you need 2 of these 3 criteria for a diagnosis. The other element that's not included here, which is very central, is that most women with PCOS, about 75%, will have insulin resistance. So you'll see that patients with PCOS have more weight gain, difficulty losing weight, particularly around their abdomen. So let's go through some basics about genetics, since what we're talking about today is epigenetics and genetics in PCOS. So we all have genes that are made up of DNA. Our genes are inherited from our parents, so we get 22 pairs of chromosomes, 1 set from our mom and 1 from our dad, and then we get 1 sex chromosome from each parent as well. Some genes that we inherit are directly carried, so you just take that gene from your parent and it becomes part of your makeup and it causes a certain trait. There are diseases that are passed like that, like Huntington's disease. So these are very obviously transmitted through a certain gene. Most other traits, though, are much more complicated. So they're governed by multiple genes and lots of different factors in the environment. In general, though, our DNA that we inherit from our parents is fixed, and that DNA, if we have a mutation in the DNA, we have a cell that turns abnormal for whatever reason, our immune system will take care of that and get rid of those cells as they arise. However, the way our genes work changes all the time, even though the material that's there doesn't. We have a lot of variation in our genes, so the variation is there for a very good reason. It allows our body to adapt to environments. So most variants can cause some differences between people, like eye color, for example, but some of them can actually be harmful. Then we have something called SNPs. So SNPs are tiny differences in our DNA. When it comes to PCOS, they've been trying to figure out for a very long time how it's passed on, because it's clear that it is. We see within families all the time that family members have PCOS. What they found is there's no one gene, so it's not like Huntington's disease. It's much more complex because so many genes can be involved in PCOS. One example of this is a gene called DENND1A. One study on 62 women found that 50% of women with PCOS had that gene. Now that's just a small study on 62 patients, so that may not be representative of the general population. However, this gene causes us to make more testosterone, so it makes sense that having that gene would increase your chances of having PCOS. So let's look at epigenetics. So what are epigenetics? Epigenetics are when our genes change their function in order to adapt to the environment. So lots of different things in our environment can cause our genes to need to function differently. So given that genes cause us to make different things that our body needs, like proteins or neurotransmitters, our body might need to change that depending on what's happening. Let's look at one example here in multi-generational epigenetic effects. This is in pregnancy and how we can see specifically with PCOS how this can happen. So if we look over here, this is a mouse who is pregnant and has been exposed to a common toxin called bisphenol A. Bisphenol A is that plastic that now is not allowed to be in babies' water bottles, but used to be. And it's everywhere in our environment. It's in everybody's bodies because we used it for so long that our environment became saturated with this chemical. What they found is that in this rat who is pregnant, if you expose the rat to bisphenol A just one time, so not ongoing, but just one time, their baby can develop PCOS, and this rat does not have PCOS. That makes sense because, during the development, this baby is developing their ovary at the time, and that alters the way the ovary develops. What they found also, however, is that this baby's baby also has PCOS, and this baby was technically inside here too, if you think about it. The second rat's ovaries are developing, and inside those ovaries are this baby. And so this one, also in the studies, this generation had PCOS as well. Interestingly though, however, even though no more exposures for bisphenol A were added, this next set had PCOS the worst out of any of the previous generations. And this one was never exposed. And so this is evidence of epigenetic transmittance through the egg from multiple generations back. So this is really food for thought. It's a lot to process, but we can really impact future generations by making changes at these key times in development. So there's different hormones that embryos are exposed to and fetuses while they're developing. The placenta makes hormones, the mom makes hormones, and then the baby makes hormones. All of those work together and they cause development of the ovaries, the brain, the adrenals. So this is a very, perfectly orchestrated system of development that's happening while a baby is developing. The brain of the baby is very susceptible to hormones. So during fetal development, boys have higher testosterone levels and girls have lower levels of hormones overall. Testosterone causes masculinization of the brain during fetal development. And then when puberty occurs, we start to see some of those changes manifest in the body. So after the baby is born, all the hormones go quiet for a long time until puberty occurs. And then when puberty occurs, you can start to see some of the results of those changes that may happen way back in the womb. There's also insulin resistance. So if there is this going on in mom or dad before baby is conceived and during pregnancy, the offspring can have the same. And we know as well that if moms have gestational diabetes, offspring are more likely to have metabolic problems like insulin resistance. The other thing that can impact the fetus as it's developing, as we already talked about, is toxins. So bisphenol A is one of them, but there's so many others like PCBs, methoxychlor, phthalates, and many others. And the problem is that these are everywhere now, and they don't break down and they bioaccumulate, meaning that once they're in our environment, they tend to stay there. We know that the whole family can be impacted by this. So we see sisters, brothers, fathers, mothers, daughters, and sons all having traits of PCOS. So just as a review, how could this happen? And we're looking here at a person who has more of an insulin-resistant type of PCOS. So during the prenatal environment, their brain, ovary, and adrenals get changed. Then at puberty, these hormone imbalances start to become evident. And in puberty, for example, we have a lot of androgens being produced in these patients, and high androgen levels cause us to gain weight by causing insulin resistance. And this actually makes it very easy to gain weight in the time of puberty and adolescence. This is where you'll see a lot of insulin resistance setting in. Now, there are many patients with PCOS who are not very insulin resistant, and we don't want to overemphasize that if they are more on the lean side. So it is really important to determine how much of that is going on. Those patients may do better with other types of support rather than focusing too much on things for insulin resistance. So what can you do about this? So during the key developmental times in life, this is when you want to really do as much as possible. Preconception, 1 year ahead, pregnancy, and puberty. Optimize epigenetics with sleep. So sleep has a major impact on epigenetics. REM sleep, losing this causes significant hypomethylation of our DNA, meaning that our DNA doesn't know when to turn off and on at the right time, its different functions. So sleep is really critical. Pesticides. So obviously, as discussed, these toxins can have a pretty long-lasting effect. So going organic for especially the most heavily sprayed foods. If you check out the Environmental Working Group, they always have an updated list on the Dirty Dozen, which means that these foods are the most heavily sprayed with pesticides. So the less of these foods that we consume, the less of this is also going into our environment. So it's not just for our health, but also for our overall population health. Plastics. So avoid plastics whenever possible. Use glass, ceramic, stainless steel. This is going to just put less plastics in the environment. You're going to have less plastics that you're consuming. So don't drink out of plastic containers. Definitely don't heat up plastic containers. Minimize food additives, chemicals, and unnecessary medications as well. Let's talk about methylation. And many of you may have heard of this because it's a very popular topic. And it's a central process to epigenetics. So what is methylation? So methylation is when something called a methyl group, CH3, which is 1 carbon and 3 hydrogens, is added onto a part of our DNA. That causes that part of the DNA to go quiet and to not make things at that time, to not make proteins or to not encode for what it should encode. It's almost like a red light on that part of the DNA. And that's a relatively stable thing. So once that methyl group attaches to the DNA, it tends to stay there for a while, for quite a while, and often for the life of the cell. And this is how things get passed on to future generations, because that mark sits around there for a long time. There's also other ways that our DNA can alter its function quickly, and these are histone modifications and RNA modifications. So these are quicker switches. There are some nutrients that are really important for methylation, and these are always very important for cell division. We'll see, we've known for a long time how important folate is for pregnancy and for embryo health, because folate is a crucial methyl donor. The folate has a methyl group attached to it that will be used directly to methylate DNA. there are different types of folate, and the active folate is the only one that can cross the blood-brain barrier, and that's called methylfolate, or 5-L5-MTHF. Some people actually have trouble converting synthetic folic acid into methylfolate, and this is a mutation called MTHFR. This is actually a genetic SNP, not a mutation, and this actually will cause a difficulty converting folic acid into methylfolate. These people do best with a pre-converted folate supplement rather than synthetic folic acid. Other methylating nutrients include vitamin B12 and vitamin B6. So these are very important. You don't want to be low in any of these when you're trying to conceive. B12 is commonly low in patients on metformin, for example, so that's something to look out for. And the other thing is vegetarians will tend to be low in vitamin B12. Folliculogenesis. So I think it's really important to understand this in the context of the epigenetics. So our eggs, before we ovulate a given egg, it begins developing about 300 days before. It goes through very early stages of development. While it's going through that development, it needs to have certain things so that that development can happen in the right way, and especially methylation is very important. However, other factors in the environment can disrupt that growth process. So basically anything that happens during that window can influence the way the egg quality is. The closer you get to the ovulation, the more influence you have because it goes through more rapid development, 30 days to 90 days before. So this is something you do want to start on ahead of time, but if you don't have time to start a year ahead, even starting 3 months ahead will still really help. So what's going on with PCOS? So I think there's a lot of misunderstanding around this. We see a lot of patients with PCOS have high numbers of follicles. They have a really high antral follicle count when they're going to go through an IVF cycle. They have a lot of AMH, which is our marker of egg reserve. So they have tons of follicles. And so it seems like, when you do an IVF cycle, if you have PCOS, or if you're trying to conceive, you've got lots of eggs. So what's the problem, right? But what we know is that the number of them is high, but the quality is low. So what you'll find if you look at this study is that the number of high quality embryos formed is not better in PCOS compared to those who have less follicles. It's ultimately around the same. And then we have another problem called empty follicle syndrome, where when women go through IVF cycles who have PCOS, they often get a lot of eggs, but they can't get the eggs out of the ovary. And this is because of a quality issue with the eggs, sometimes a combination of the eggs and the medication protocol. Look at this study here. It shows that starting off, the patients with PCOS had about 14 follicles to start off with, and the non-PCOS patients had around 9. So the patients with PCOS you would assume would do better, and this is an IVF cycle. So as the patients, these oocytes start to go through fertilization, we start to see the numbers really dropping. You'll also see at the bottom here that ultimately the pregnancy rate is lower with PCOS. So the quality is the problem here, not the quantity. Why is that happening? It's because our eggs are surrounded by these follicles. The follicle actually includes the egg along with many other cells. So these cells on the inside are called the granulosa cells, and they provide nutrients to the egg inside the cell. So lipids that are actually stored inside the oocyte. So lots of those are in there, and those are really important for energy production in the egg. The follicular fluid environment right here really represents the overall metabolic environment. So if someone has insulin resistance, there's definitely changes that would happen here. So what affects egg quality in PCOS? We have 3 main areas that it can be affected. The first is inflammation, the second is androgen excess, and then the third is high insulin levels or insulin resistance. So these are all very important and can negatively affect egg quality. Let's talk about cholesterol. So we'll see a lot of patients with PCOS have high bad cholesterol and low good cholesterol. This is because of the insulin resistance that you'll see in PCOS. And HDL cholesterol is really important for egg quality. So that good cholesterol really helps support egg quality. Androgens, another reason for the egg quality problems. So androgens are really important. As you'll see here, we're at the beginning of the month, and we're getting ready to start off with a antral follicle. This would be the egg that would be at the beginning of a cycle, like cycle day 1. To get the egg up to that point and to get it ready, androgens are really important. So we need those to help the eggs to become ready to ovulate. They help communicate between the cells inside the follicle, and then they're also involved in the final stages of development of the follicle. Too much of androgens inside the ovary, though, slows the eggs from developing fully and interferes with the cell division of the egg and can cause inflammation and oxidative stress. So although we want androgens, we don't want too much either. So it's all about that balance. We want the right amount of androgens. One of the treatments that we use at our clinic is cyclic progesterone therapy for high androgens. It's a very effective treatment where we give progesterone for 2 weeks of the month. And this is to mimic the natural progesterone that we make for only 2 weeks out of every cycle. As you'll see here, the first part of our healthy menstrual cycle, there's no progesterone. And then in the second half, we have a good amount of progesterone. So when we use cyclic progesterone therapy at our clinic, we provide that every 2 weeks, 2 weeks on and 2 weeks off. This causes feedback to reduce excess androgens in patients. And so this is something where, if a patient has very high androgen levels and they've already taken care of, everything else that they can, this is an amazing treatment that works really well. It was pioneered by Dr. Jerry Lynn Pryor at the University of BC. And then let's look at insulin resistance, because we've talked about it, and it is one of the factors we can actually address and affect. We can make a big difference for insulin resistance, and this is going to improve egg quality. It also improves overall health in PCOS. So we're looking at the lifelong, pattern of PCOS, all the different risks like diabetes, cardiovascular disease. All of these are going to be improved by working on insulin resistance. So how do we figure out if you've got it? Firstly, I get a lot of patients who come to me and say, well, I've had my sugars tested and I don't have insulin resistance. Testing your sugars will not rule it out. So what do we see in patients? We see them gaining weight around the belly. So they're not gaining the weight on their hips and thighs. It goes right to their stomach. Fatigue, especially after eating. Cravings for sugar and carbs. Skin tags, so little skin growths on the neck that are flesh colored. Dark velvety skin patches, especially in the folds of the skin that you can't wash off. That's called acanthosis nigricans, and it's a sign of insulin resistance. How do you know if you have insulin resistance? If you want to look at labs, checking your sugar is not going to tell you. So if you have a practitioner, you could show them this information, but they would need to measure fasting insulin and fasting glucose. Optimally, a fasting insulin should be under 50, and a fasting glucose should be under 5.2. There's a calculator online that you can take those two values, enter your numbers, and determine your HOMA-IR. HOMA-IR, as a cutoff of 2.5, has been found to be, that's the line for insulin resistance. Another study found 1.7 was the line. Another way of testing it very easily at home is by checking waist circumference. So if your waist circumference is high compared to your height, that's called the waist height ratio. This is a sign of insulin resistance. So there's online calculators that you can use to figure out. You just measure your waist and your height and input that. It's quite an accurate way of telling if you have insulin resistance. We can see that in insulin resistance, that fluid has more glucose, it has more free fatty acids that are inflammatory, and those cause damage to the mitochondria inside the eggs. And miscarriages. So we often see insulin resistance associated with miscarriages, and these affect the embryo growth. So the placenta is affected as well. In pregnancy, insulin resistance is actually normal. So if you have it it's really to help you gain weight. If you have it to an increased degree before you start, it's going to go even further. So helping to work on that during pregnancy and also before is always really beneficial. And so what can you do with nutrition? Many nutritional programs can work, and there's no right diet. I always say it's what will help you feel full and satisfied and something that you can continue long term. The way that I tend to recommend for my patients is to consume 25 grams at least of lean protein per meal, which is about the size of the palm of your hand. Non-starchy vegetables, 2 or 3 cups a meal. Healthy fats, about 1/2 cup of nuts, seeds, avocados, or 1 or 2 tablespoons of a healthy oil, like olive oil or avocado oil. And then quantity controlled carbs. So carbs can be included in a PCOS diet, and just the quantity may need to be moderated. This might need a practitioner to figure out for you. But in general, if you're not taking too many carbs in during that meal and balancing it out with those other categories, this is going to make a huge difference. Exercise is one of the things that makes a huge difference. Skeletal muscle can increase our metabolic rate, but also if you're increasing your muscle mass, you're going to increase the number of GLUT4 receptors. These actually dispose of glucose more efficiently. So exercise is really, really good to do if you have PCOS. A lot of people ask, what kind of exercise should you do? I think many types can work for PCOS. I think it should be the type that you enjoy, that you'll keep doing. And if you can include strength training in there, it really gives you a lot of effect. Sleep and insulin resistance. So sleep and fasting. So there should be times in the day when you're awake and eating, and there should be times in the day when you're asleep and fasting. The reason for that is different metabolic activities happen at different times. This is why we see so many people who do shift work have metabolic problems, or who have insomnia. So we do really want to dial in that sleep and, have a cutoff time from eating. So let's look at some of the supplements. And, this is something you should really consult with a practitioner for, because many of these supplements do have overlap. And some of them suit certain people and not others. And there's always ones that will suit you best. And there's certain ones that are not indicated for everyone. So it is always important to discuss that with a practitioner. So we have supplements like inositol that can help with insulin sensitivity. Then we have a lot of our antioxidants that support the mitochondria, like coenzyme Q10, PQQ, alpha lipoic acid, carnitine. We have a lot of other anti-inflammatory antioxidants like resveratrol, polyphenols, and N-acetylcysteine. So these are just a few options. There are so many different possibilities when it comes to choosing supplements. But it's really just an overall plan that's needed to help support all the elements of PCOS in your case. Not everybody has insulin resistance, and so we want to create a plan that will address your unique presentation of the condition. So as a review, what do we need to do when it comes to epigenetics specifically? And this is more about fertility and future generations than it is just about overall health, although many of these elements will help overall health with PCOS too. If you want more information on overall health with PCOS, please check out my book, 8 Steps to Reverse Your PCOS. With epigenetics, we want to work on at least 3 months, or ideally 6 months to 1 year before trying to conceive. We want to increase our insulin sensitivity, especially if you are insulin resistant. Minimize toxins, optimize sleep, exercise, and stress reduction. Support oocyte and follicle health, so egg quality with antioxidants and supplements. And then optimize nutrient and lifestyle to support methylation. So thank you so much for attending my presentation today. I hope it was useful for you in that it gave you a few tips, but also an overall understanding of PCOS. So I hope that this will help stimulate your interest in this area. And again, I just wanted to thank you for attending the symposium this year and for the opportunity of being able to present to you. So have a wonderful day. Enjoy the rest of the symposium.